Hello, everyone, and thank you for joining us today. Welcome to our webinar on antibiotic resistance, understanding the challenges and possible solutions. My name is Amelia Ello, and I work as a specimen processor here at Absolute Genomics. Our goal today is to provide information to healthcare providers, academic researchers, and the general public about the mechanisms of antibiotic resistance, the key elements of antibiotic stewardship, and how important it is for patient care and improving patient outcomes, new and emerging technologies and platforms, the advantages of antimicrobial resistance reports, the genomic workflow for antibiotic resistance, and strategies and approaches for getting started. We will also answer the questions, can antibiotic stewardship cut costs associated with infection management? And does practicing antibiotic stewardship reduce infectious outbreaks in healthcare settings? Today, we will have two speakers with extensive experience in the understanding of antibiotic resistance. They are Dr. Umar Rahil, Director of Operations, and Rachel Menina, General Supervisor. Our webinar will consist of a 15 to 30-minute presentation by our speakers, followed by a 5 to 10-minute Q&A session. We encourage questions to be entered into the chat during or after the presentation. We hope this is informative and educational for everyone attending. I will now give the floor to our first speaker, Rachel Menina.
Thank you, Amelia. Hello, everyone. Today we are presenting a huge issue that affects the healthcare system globally. I will first start off by going over what exactly antibiotic resistance is, along with how it occurs, followed by the challenges we face while trying to combat these issues. And then we will go over how we can offer you all some solutions to handle this issue, as well as interesting future developments. So I'd like to demonstrate to you all how dangerous antibiotic resistance is. And as we can see from this graph, antibiotic resistance is expected to overtake cancer as the top cause of death by 2050. Now, according to the CDC, antimicrobial resistant bacteria will raise the death rate by 40%. It has also been named one of the top 10 public health hazards by the World Health Organization. Knowing this, we can get an idea of how critical it is to consider antibiotic resistance when prescribing antibiotics. I'm having trouble, I'm so sorry. So what is antibiotic resistance exactly? I'm so sorry. So when a patient is, antibiotic resistance is when patients encounter infections that are resistant to the bacteria, resistant to the medications that we give them. When a patient is diagnosed with a respiratory infection, they are frequently recommended a Z-Pak or another antibiotic to begin without further testing. And I know this because it occurred to me several times when I was a kid. I never had a respiratory swab taken, and then I ended up in the hospital with pneumonia, which took a very long time to treat. I was unwell for almost 5 months, so every day you have patients with bodily infections, whether they're wounds, respiratory, or even sexually transmitted infections that are becoming increasingly difficult to treat. So as a result, the patient is on antibiotics for longer than necessary. And this can lead to severe problems since the infection spreads, and some broad spectrum antibiotics can kill the beneficial bacteria while the harmful bacteria thrive, resulting in unintended consequences. And I'll go into this further detail about how this happens. But first, I'd like to highlight a few key pathogens where antibiotic resistance is common and a significant source of concern in healthcare. So here is a CDC infographic listing some of the most prevalent pathogens, some of which you should be seeing in your patients with bacterial infections. Now, MRSA is something that we're all very familiar with, especially in wound infections, particularly among the elderly. Staph aureus is often resistant to methicillin, but it also has resistance to vancomycin and other beta-lactam medicines such as penicillin and amoxicillin. Enterococcus faecalis is a pathogen that causes urinary tract infections, wound infections, and in some cases, vaginal infections, and can become resistant to vancomycin. Vancomycin-resistant Enterococcus is a highly aggressive pathogen that can be difficult to treat due to resistance to multiple antibiotics, such as penicillin, ampicillin, and imipenem. Some antibiotics are still effective, but the trial and error period increases the risks of infection spreading and treatment delays. An enterococcus not only contributes to these infections, but it can promote bacteremia or sepsis if left untreated. Multi-drug resistant Pseudomonas aeruginosa is a common pathogen in nursing homes and long-term care facilities. It is challenging to treat due to its ability to form biofilms that allow for increased bacterial colony growth. And this usually occurs when a catheter is in place, resulting in a severe urinary tract infection that is extremely painful and uncomfortable for the patient. Only a few antibiotics, such as fluoroquinolones and gentamicin, are effective against this pathogen. According to the CDC, more than 2 million people will become ill due to antibiotic-resistant pathogens, with at least 23,000 deaths. And so as a result, it's not surprising that antibiotic resistance is linked to a high mortality and enormous economic costs. Now, I wanted to inform you all about a pathogen involved in secondary infections due to the misuse of antibiotics. So now, not only do we have to worry about antibiotic-resistant infections, but we also need to worry about secondary infections, particularly by Clostridium difficile. So C. difficile infection is a product of antibiotic usage, and usually people who contract this kind of infection either are taking antibiotics or they have taken antibiotics within the past 4 weeks. And after taking antibiotics, it actually takes the gut around 6 months to heal because the microbiome is completely upset by the medication. Now, as I'm sure most of you know, C. difficile is a serious infectious pathogen and it spreads very easily. It's actually responsible for 29,000 deaths and around 450,000 infections every year in the United States, based on data reported from the CDC. Now, C. difficile is actually a relatively normal intestinal bacteria, but when taking certain antibiotics, such as these 5 listed here, it allows for C. difficile to replicate rapidly, leading to serious discomfort in the patient. However, there are definitely antibiotics that do work against C. difficile, such as metronidazole, vancomycin, and fidaxomicin. But either way, all of these antibiotics disrupt the patient's entire immune system, making it very hard to recover. And believe it or not, this pathogen is not normally antibiotic resistant. Most treatments just aren't effective or selective enough to control the overgrowth of this flora in the gut. C. difficile infections cost the healthcare system about $45,000 per patient because of how difficult it is to treat, and it often leads to hospitalizations or fatalities, especially in elderly individuals. Another issue that may contribute to this is we have seen a lack of staffing in these long-term care facilities and nursing homes, which causes the current available staff to be overstretched amongst the patients, leading to lower infection control and prevention, which is why it is so important to test your patients to properly diagnose and treat them with medications that are going to work against what is making them ill. Now I'm going to talk about another secondary infection that is associated with COVID-19. Now, I know that we are all probably tired of hearing about COVID-19 and the total disruption that it caused our society. However, there was a certain practice in place where patients came in with COVID-19 or even just symptoms prior to infection confirmation, where patients were dosed with antibiotics almost immediately as a preventative measure to reduce the chance of pneumonia. And so pneumonia, like C. difficile, is a secondary infection in this situation. And unfortunately, since pneumonia can be either viral or bacterial, hospital staff figured it was best to treat patients with antibiotics right away. But unfortunately, this likely led to an increase of antibiotic resistance. And there were a few pathogens that became more resistant, some that would not be associated with pneumonia, but one in specific that can lead to pneumonia was carbapenem-resistant abomani, which was found in an acute care hospital in New Jersey. Other organisms reported were Klebsiella pneumoniae and Pseudomonas aeruginosa. And of course, since the types of bacteria in our bodies can vary, it is highly possible to develop resistant bacteria that are not associated with what is making your patient ill. Now, since hospitals and laboratories and the healthcare system as a whole were so immersed in COVID-19 and the proper testing practices, other forms of testing were pushed to the side. But looking over the data, only 6 to 15% of people infected with COVID-19 actually acquired bacterial pneumonia, meaning we were dosing people incorrectly with medications they didn't actually need before they even developed an infection. We see now a lot of our patients will choose to be tested for not only COVID, but the full respiratory panel because the prevalence of COVID is so much lower. And now we can actually see a rise in normal infections such as the flu or the common cold. And this is not to say that these other infections were not present, but not only were people less likely to be tested for other respiratory infections, the amount of antibiotic resistance testing also went down. And again, this is because of how devastatingly fast COVID spread, and that became the main focus. And since COVID is a virus, it cannot be treated with antibiotics, so there were no reflexes to antibiotic resistance testing. So I'm sure you're all wondering how this actually happens. How do bacteria become resistant and spread their resistance amongst one another? Well, first, I want to go over and explain how antibiotic-resistant pathogens share genetic information. And this can happen between different pathogen species, leading to multi-drug resistance. This CDC infographic shows that there are three main methods for transferring antibiotic-resistant genes. The first is transduction, which occurs when bacteriophages, which are viruses, in your body attack the bacteria and they pick up the genes and they are transferred to other bacteria. The second and most common method of transferring genes from pathogen to pathogen is conjugation. When bacteria connect, they exchange genetic information and produce new bacteria with resistance genes. Transformation is the third method here, which is more of an independent acquisition. The bacteria will pick up these genes that another pathogen, whether alive or dead, has previously released. So we can see that because these pathogens can acquire resistance genes in various ways, it is more challenging to slow the rise of resistance. And this is where we must step in and make a conscious effort to avoid antibiotic overuse by testing individuals first to see if they are even infected with the bacteria, followed by antibiotic resistance testing to see if the pathogen contains any resistant genes before treating patients. Also, bacteria have multiple forms of resistance, such as removal of the antibiotic, restricted access, and destructive enzymes, such as beta-lactamases, which target beta-lactam group antibiotics, such as penicillin and amoxicillin. Following this slide, I would like to go over a challenge known as differential resistance. So what is differential resistance? So differential resistance occurs when a bacterial colony contains multiple species of bacteria with diverse resistance mechanisms. Viruses, for example, COVID, can have multiple variants, as we all know. The same is true for bacteria that may have multiple strains. As a result, we can see how two different antibiotics can affect different pathogens in the same colony. The goal is selectivity, and we want our patients to get the proper medication to fight the infection. So we can see the distinction between both antibiotics A and B, which are both used to treat multiple pathogens simultaneously. But because of resistance from the pathogens to either antibiotic A or B, both antibiotics A and B are having difficulty destroying the bacterial colony. While this resistance develops in our bodies, the antibiotic also kills the beneficial bacteria. And the microbiome in our gut is critical to immune health and response. So when antibiotics cannot treat an infection while simultaneously weakening our immune system, the infection is allowed to grow and spread. And unfortunately, this results in the need for additional care or fatalities in the worst case scenario. This is especially true for elderly patients or anyone with a compromised immune system, such as patients in nursing homes or long-term care facilities, where multiple infectious pathogens can spread easily, which can again lead to the secondary infections due to the disrupt of the body's normal flora while taking antibiotics. Well, now that we've discussed what antibiotic resistance is, how it occurs, and how dangerous some of these pathogens are, I'd like to highlight a few ways antibiotic resistance bacteria can spread amongst your patients and how we can implement some preventative measures. So of course, while being exposed to bacterial pathogens while you're in close proximity to sick people, such as in a hospital, a long-term care facility, or nursing home, it is the most common way to acquire the pathogens, especially because bacteria can cling to surfaces and be transmitted to anyone that comes into contact with a contaminated surface, or even possibly contaminated tools, such as scalpels and catheters. But on the other hand, the agricultural industry largely contributes to the spread of these resistant pathogens. According to the World Health Organization, farm stock accounts for approximately 80% of antibiotic use. And so these animals are given antibiotics to prevent infections, even without any sign of infection, while also bulking them up. And so unfortunately, the antibiotics are introduced into their guts, and it allows any bacteria they have to develop resistances. And these pathogens can then linger on meat and be consumed by humans, which is why it is recommended to cook your meat to a certain temperature. And I'm sure when you go to the grocery store, you will see meat. It says never raised with antibiotics, no antibiotics were used. You'll also see it on some yogurt brands and also milk, which is good. You definitely want to purchase food without antibiotics. But unfortunately, infected feces can also contaminate water, fertilizer, and then be applied to crops, which is why it is critical to thoroughly clean your produce. Because I know that we have all heard of the romaine lettuce E. coli issue. Now that I know that I've mentioned nursing homes and long-term care facilities quite a few times, and I would like to go over how important it is to practice proper testing methods to control infection spread in these establishments. So, believe it or not, the most common establishments where infectious pathogens spread rapidly are not only hospitals, but nursing homes and long-term care facilities. The main issue here is that the majority of patients in these establishments are elderly, some of which may be immunocompromised. And these kinds of institutions are the perfect places to contain an infectious pathogen, allowing it to thrive. Patients that are transferred from hospitals can also introduce bacteria into the institution, further putting current residents at risk. The most commonly associated infection in nursing homes and long-term care facilities are UTIs, mainly caused by multi-drug resistant pathogens, likely Pseudomonas, as we mentioned earlier, which creates biofilms and catheters. Residents are more likely to be treated with antibiotics, and residents that are treated improperly are 5 times more likely to die from the infection. So why are we seeing an increase of antibiotic resistance in these areas? Well, 47 to 79% of nursing home residents receive systemic antibiotics each year, and antibiotics are prescribed for 77 to 88% of all infections. Not to mention the secondary infections that are produced by the misuse create another easily spread infectious pathogen, such as C. difficile. Now, moving forward, I will hand over the podium to Dr. Umar, who will discuss some of the current solutions for dealing with antibiotic-resistant infections, starting with antibiotic-resistant stewardship programs, which are an excellent approach to combat resistance. He will also be going over how absolute genomics can play a role and provide solutions to all current healthcare establishments. But before I go, I want to ask you all, and please feel free to put your answers in the chat. How many of you experience these challenges, and how does it affect your operations? Thank you. Okay, Dr. Umar, the floor is yours.
Thank you, Rachel. Thank you so much, Amelia. Both of you did an amazing job. And now we have this background on antimicrobial resistance, how it occurs, which are the top culprits. These were all the challenges that we are facing. Now, what are the solutions, and where does absolute genomics fits in this equation? So let me give you a brief background. Each year in nursing home, there is a usage of antibiotic, which is around $130 million. So you can see the magnitude of how people are being prescribed. The biggest problem with that is that 25 to 75% of those antibiotics are misused. So either they are not recommended for that specific bacteria, or they are used preventively. So there is this misuse, and that is one of the leading causes for antimicrobial resistance and secondary infections. Another huge thing is that in next 5 to 10 years, there will be 72 million people adding to the nursing home and long-term care facility system, which is going to really burden up the healthcare system. And we need to prepare for that burden, and that whole health care system needs to evolve to meet those requirements. So when it comes to absolute genomics, we looked into different avenues which can help us create a proper stewardship program for antimicrobial resistance. As you know, there are four main bodies that are involved in this. Is Sanford guide, it's John Hopkins, CDC, and NIH. So at Absolute Genomics, we wanted to trickle all that information into a single report, and we were able to achieve that. So let me explain to you like how does Absolute Genomics report looks like. So first of all, this is a wound care report, a patient who had a wound infection. The report will first of all tell you which kind of pathogen is causing the infection. In this case, it's Staph aureus. The second part of our report is like what is the mechanism of antimicrobial resistance if the bacteria is present. So in this case, it's MAC-A gene, which confers methicillin resistance. So it's MRSA Staph aureus bacteria. So this is the first part of the report where we identify the problem. How do we resolve the problem? So this is how our antibiotic stewardship looks like. So our stewardship report has different features, and I'll quickly go over them. So the first of all, you see the infection complexity score. So right now you see the score at 2, so it's not very complex. What are the things that contribute to the infection complexity? It's the type of pathogen, the type of resistance, if it's a single pathogen infection or it's a poly pathogen infection. All these factors will contribute to the complexity. So we are providing this powerful information to the physicians so they can determine how complex the infection is, and then they can provide the appropriate treatments. The second thing on the report on the left side, if you can see, is the organism detected. As I told you before, we will mention which is the organism and what's the resistance mechanism, and under that it's the resistance detected. So in this case it's methicillin, and again you see that score. We also tell you like how complex is the resistance. So in this case it's a common methicillin resistance. We are all very familiar with it. Another important thing that comes with our report is like the allergic information for different patients. So we have heard a lot about penicillin resistance. People have sulfate group resistance. So in that case, if we have the history for that patient, we will recommend drugs that don't contain those groups, but they are still effective against that pathogen. So that's another powerful tool. And finally, we give you the drug information. In case of drug information, what distinguishes us from the other reporting bodies is like we give you one best choice. And how do we reach this one best choice? As I mentioned earlier, we look to Sanford guideline, John Hopkins guideline, NIH, CDC. We get all this information on the resistance mechanism, the dosage, what are the effective molecules against those pathogens, and we trickle all that information into this single report. So this is the basic report. But if a doctor, for example, got to know that later on that the patient had a history of some allergic reactions, what are the alternatives? So if you go on the next page of our report, it's called Med Matrix, where we give you a bunch of other medications. So if the patient is allergic to one medication, we have a list of other medications that are equally potent against those pathogens, or pathogen in this case. So these things really make our report very powerful. And this is kind of our way of fighting antimicrobial resistance, because this is affecting the global health. And believe me, before COVID, it was one of the main concerns for WHO and all the major infection control organizations. So in a way, Absolute Genomics is trying to contribute towards infection control by providing proper medication for proper pathogen, and we are kind of avoiding the resistance spread by inappropriate use of medication. So it's a tailored, targeted treatment for a specific pathogen. Now, since we learned about the treatment regimen, the resistance mechanism, I wanted to educate our audience on what are the futures for antimicrobial resistance, because we can slow down this process, but we cannot stop this process. Because evolution takes place in nature, and these bacteria are evolving with every cycle of growth. With every progeny, there is mutation and there is resistance that is coming up. So scientists are continuously fighting this uphill task to come up with mechanisms to fight off this resistance. So two of the approaches that are very great, and I can see some of the medications coming in the market soon. In the next 5 years to 1 decade is phage therapy. So phage therapy is basically a virus bacteriophage that infects a bacteria, and then it can be used against that bacteria. There are some concerns for using phages inside the body, but to avoid that, the initial trials are focusing on wounds that are topical wounds, so outside the skin, outside the body, and the results are amazing. So I know a lot of these phage therapies are in the last phases of trials, and you will see some of the products in the market very soon. Finally, this is nanotechnology is huge. You know, we have heard so much about nanotechnology when it comes to vaccines, delivery, drug delivery, from cancer to autoimmune diseases. Nanotechnology is used in every aspect. So scientists are also harnessing this technology, especially the nanoparticles, metallic particles, against bacterial and viral and fungal pathogens, and there is a huge success also. So look out for these technologies in future, and you will see some amazing products that would help us curb the antimicrobial resistance. But the bottom line is, the message is, use antibiotics in a proper way, safe way, and only use them when they are needed. With this, I would like to thank everyone for being patient, listening to us, and we are here to answer all of your questions. If you have questions after the presentation, you can reach us on these emails that I've shared. With this, I will give the podium back to Amelia, and thank you.
Thank you, Dr. Raheel. Before we do take time for questions, I just wanted to let you guys know that the CDC is offering some free trainings on antibiotic resistance if you are interested in this topic. So there are 13 free trainings on the CDC website, and they're offering up to 10 free hours of continuing educational credits for all healthcare workers. So now we will take time for questions, and any that cannot be answered in time, feel free to contact us at the emails listed in the presentation here. Okay, so first question. We see lots of fungal infections in our nursing homes. Is antifungal resistance common? And if it is, do we have any tests to detect any antifungal resistance?
So that's a very good question. The fungal resistance is an emerging problem right now, and it's serious in some cases. So there was a fungus, Candida aureus. It was people started calling it superbug because it was untreatable. We had some small outbreaks in New York also, in a long-term care facility setting, especially for aging population, because these fungal pathogens usually attack people who are immunocompromised. Either they are aging, or they are on those immunosuppression therapies. So to answer the question, right now there is an emergence of fungal resistance, but right now we don't have any test because the magnitude of problem is not that huge. Usually all the antifungals are working against the fungal pathogens, and our focus more is right now on nail fungus. So we are looking at trichophytans like Trichophyton rubrum for nail fungus, or candida. So those are treatable. So right now the focus is not on fungal resistance. Bacteria is the main target right now.
Okay, thank you. Next question. Why can't we just make more antibiotics and market them?
That's a very good question. Rachel, you want to take that? I know.
Yeah, sure. So believe it or not, it actually takes about 10 to 15 years to develop a new antibiotic, and it can cost up to $1 billion. And unfortunately, it's not very profitable for pharmaceutical companies.
To add to that also, it's a continuous process. Research is going. Antibiotics are not the answer. We have to look at other avenues, whether it's nanotechnology, phage therapy, because it's a constant battle with these pathogens, and you have to be proactive and innovative. So people are trying different approaches, and as Rachel said, it's not an easy process. It takes a lot of time, lots of resources, but we are trying our best as a community to reach there.
Thank you. Next question. How prevalent is the use of bacteriophages to counter ABR?
Take this.
That's for you, Amar.
Okay.
How prevalent is the use of bacteriophages to counter AMR?
It's very common, but again, these things are still in clinical trials, and the trials are very good, like reassuring right now, especially for wound care. I know several products that are in their last phases of the trials. So in future, as I told you, in next 5 to 10 years, you will see some of the products coming out, but we have to be prepared for that. That bacteria is also evolving. Once we start using phage therapies, they will come up with mechanisms to avoid phage therapy also. So with phage therapy, I think we will also need some constant, innovation also, maybe coming up with new phages. A lot of the phage therapy research is mostly directed against the resistant pathogens like Pseudomonas and Staph aureus. It's promising, but only future will tell us how promising it is.
Okay, thank you. Can someone clarify how PCR testing is superior in comparison to culture testing for antibiotic resistance?
So, we have gone over this in our last webinar also. So there is a huge difference. Culturing was a great technology. It's been used for decades now. But since the evolution of molecular biology, now PCR is the next generation of testing. So its PCR is more accurate. First of all, the accuracy is usually above 96%. And when it comes to culturing, sometimes it can be 70 to 80%. So that's a huge difference. The second and most important thing is the turnaround time. With PCRs, the turnaround time is usually same day or next day, 24 to 48 hours, while culturing takes almost 4 to 5 days. And in case of fungal and viral pathogen, it can take weeks to months. We cannot wait that long for the results to treat someone. So PCR is the most robust, accurate approach that is in the market. The future holds new things, and next generation sequencing is also coming up, and we are trying to harness that as well. So, but the biggest challenge with next generation sequencing is against the turnaround time. So at Absolute, we are trying to come up with solutions that are cost effective, and also that can cut down the times with next gen sequencing. We will do that too, because we want to be the leaders in the market. So, but right now, PCR as it is the most accurate and fastest technology out there.
Next question is, how do nanoparticles help in the efficiency or specificity of antibiotics?
So these are two different things. So antibiotics and nanoparticles, they can, so antibiotics are of course the common antibiotics we take, and nanoparticles are the metallic particles or different particles that can be used against bacteria. It's a question. There are studies that people are using them both together to see the effect, and they are very potent. But this is still an open research. It's at a very preliminary stage. We cannot conclusively say at this moment where they are. I usually say, it's in its infancy right now. So maybe in next 4 to 5 years, we will know how it can be used. But nanotechnology is being used especially for targeted delivery also. That's a huge issue too, because if we want to target a bacteria in a certain location, nanotechnology can play a role in that as well.
Okay, it seems like that is all the time we have for questions today. If you did not get your question answered, you could email Dr. Raheel or Rachel at the email addresses provided. But in summary, today we have learned about antimicrobial stewardship, new and emerging technologies to identify antimicrobial resistance, and the different strategies and workflow processes involved. If you would like more information on this topic, you can visit our website, absolutegenomic.com, or visit our LinkedIn webpage, which we post regularly on.